have to remind me to turn the recording on. How's that? Let's try a peripheral one. So you get the idea of this now. This is much better if you do your own essential illness scripts than if you rely on somebody else's. Because you have to reason your way through this, and that's a learning process all by itself. So let's try this. A torn posterior cruciate ligament. Okay, again, 3 or 4 questions, couple or 3 tests. And we'll make this an acute problem. So it's a recent onset. Okay, so a week. It's traumatic.
Can you repeat that, Jim?
We've got a torn PCL. Okay, post-traumatic. You're seeing it a week after the trauma. What's the essential illness script for that?
Mechanism, asking the patient mechanism, like how, because it's acute.
Okay, let's try that first. I was playing rugby, somebody tackled me and they forced my knee into abduction. Okay, so they hit me, my right knee, they hit me on the right side, forced me into abduction. That's one particular possibility. Another one was I was in a car accident and my knee slammed into the dashboard. Another one was, I don't know what happened. I was playing football and I got tackled. I really don't know what happened. Now, 3 different mechanisms. Does that help you out that you've torn the posterior cruciate ligament? Doesn't really, does it?
Not really, yes.
Like, this is a patient presentation, yeah? So usually the mechanism doesn't make any real difference unless, no, the mechanism of the trauma doesn't make any real difference to anybody because there's so many ways you can get stuff injured that there's nothing really very specific about it, the mechanism of injury. If you've got a massive trauma, then it's an explanation for massive disruption. If you don't have a massive trauma, then it's not an explanation for massive disruption. With me? But that's not the same thing as saying the mechanism that will lead you to a diagnosis. Yeah. So let's go with pain. What you got? Where is the pain? Who's seen a PCL tear soon after the trauma? They're not that common, I agree, but has anybody seen one? Okay. Can we say the pain's in the knee then?
Yeah, pain is in the knee.
Generally, it's on the inside of the knee. That's usually where it's felt worse. Most things in the knee are felt worse on the inside of the knee. Yeah. So we've got knee, it's probably going to be medial knee pain. What else? Functional loss or not functional loss?
There might be functional loss.
Yeah, they're not going to walk on this. They may limp on it, but they're not going to walk on it. So we've got obligate functional loss. Yeah. Swelling.
Yes.
How quickly does the swelling come on?
That could entirely depend upon the grade of the injury too.
Actually, usually not. There's a reason for it. You could recommend if they've got obligate functional loss, this is not a mild injury. There's an artery that runs with a ligament, and that usually gets torn. So what you have is hemarthrosis.
Hemarthrosis we get immediately.
Yeah, very, very rapidly. You'll get massive swelling within an hour or so, massive amounts of swelling. Whereas if this is purely inflammatory, you're going to see it later on. It'll get worse by the next day. This is massive and it's very rapid. And the swelling, if you try and fluctuate it, it doesn't fluctuate. It doesn't flow from one area to another. It moves as a glob, boom, 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 because it's actually a very viscous fluid. You also get this with intra-articular fractures. Same thing happening there. So this is not so much about you not being able to do this, it's about knowledge gaps. You've never seen a posterior cruciate ligament before. You've forgotten what you learned about it in school. Yeah? How many of you doing sports? Anybody? Like heavy sports practice? Nobody's working with field players. There's no reason to keep that piece of knowledge. But this is all very common stuff. Hemarthrosis with PCLs is very, very common. Now, this is a kicker though. When will the pain come on in relation to the trauma?
Right away.
Within an hour or 2 hours, depending on how good your pain mediation system is. So the better the better that you mitigate pain, neurophysiologically block pain, the longer severe pain comes on. But generally speaking, you can say that the severest pain you're going to suffer from this trauma will be either immediate or within an hour or so. And it won't be worse than that. Well, it will do if you jump up and down the bloody thing. But that stuff right after trauma is as bad as it's going to get. So it's the onset of an immediate onset of the severest pain if they're not being stupid with it. Yeah. So that's a kicker. That indicates then healthy tissue disruption. Fractures, ligament tears, muscle tears. Any healthy tissue that's disrupted by the trauma, that pain will come on very, very rapidly. So while you may not know what this is, you may not be able to diagnose as a PCL, what you can do is say the illness script for severe tissue disruption is an immediate onset of severe pain after or at the time of the trauma or shortly after. There's your illness script. And you may well not be able to do. Stress testing this is not going to be terribly worthwhile because there's so much effusion in there, so much goop in there that it's stable. And usually these tests are negative anyway. And remember that the chances are the part of the ligament they've torn is the anterolateral fiber. So Lachman's test is likely to be positive, but the knee flex test is quite possibly going to be negative anyway. And you won't be able to get enough extension on the knee to do a Lachman's test anyway. So going back to what we said before, this is going to be a flexion and extension impairment. They're not going to be able to move the knee into flexion or extension. Objectively, you're not going to be able to move the knee into flexion or extension. And it really doesn't matter whether this is a PCL tear or this is a traumatic arthritis or an intra-articular fracture or a meniscus tear, come to that. The joint is so damaged by the trauma, it's going to flare up. You're going to get inflammation in there and you're going to have traumatic arthritis. And that's about the best you can say about it. You see exactly the same thing with motor vehicle accidents. Severe neck pain, limited, like quite severely limited movement as well. 50% loss is not unusual in a car accident, is it? But can you tell me what damage has been done?
No.
It's certainly not from a clinical exam, except if this is an onset of immediate severe pain, this should go to the emergency room, especially if the pain is central. Now, if I've torn here, if I've torn the sternomastoid maxim, I'm going to get severe immediate pain. Now, I'm not too worried about that being a fracture. Yeah. What am I worried about though? That might be.
Third fracture.
No, it's not a fracture, is it? It's out here. What about fracture?
No, no fracture. If it is central.
Hmm?
If it is central, so we'll be worried about it.
Pain, I've got severe pain right there. Anterolateral neck. Sternomastoid is your best bet, but there is something much more severe that could occur there. What is it? This is about anatomy now. Look at the anatomy in the area.
Clavicle.
Hmm?
Clav.
Trap,
Carotid artery stenosis or something like that.
carotid artery. That gets torn. So while it's almost certainly going to be a sternomastoid, it may be a carotid artery tear. So how are you going to differentiate? And then we can look at the illness script for both of them. So differentiate the two.
Pain with active movement might be sternocleidoid.
Well, no, because if you're moving, like these both run in exactly the same direction, don't they? Basically, they both run here. Yeah. So if I'm moving the neck, the carotid artery is moving. That's loaded with nociceptors, so that's going to be stressed by the movement as well.
Presence of a bruit.
You're going to listen to it. Are you good at doing that? When was the last time anybody listened to the carotid artery?
Do a cranial nerve test?
Well, actually, it doesn't do the cranial nerves.
Oh.
And this is interesting. If you damage a vertebral artery traumatically, the consequences tend to be much worse than if you tear the carotid artery. It's interesting, but that's a fact. It hasn't got the same sort of consequences, unless it fires off a embolus, in which case you're going to have a cerebral stroke, not a brainstem stroke. So there may be no neurological, and there's usually no neurological signs with a hindbrain stroke, VBI stroke, for a couple of weeks or 3 weeks, or symptoms. You can't really test. Testing for the strength of sternomastoid doesn't work terribly well. Because you still don't know what's happening. The thing is palpation. That's your easiest tool. If I've torn the sternomastoid, then the sternomastoid is going to be bloody tender to palpation, isn't it? If it's not tender, then I have to assume it's not the sternomastoid, which only leaves me the carotid artery. But you can't palpate like that, because now you're palpating the carotid artery. You have to come in and pinch it this way. If that's negative, though, it goes to the emergency room.
When it is sternocleidomastoid, can we expect ecchymosis over there, bruise over there?
Sorry, say again.
When it is sternocleidomastoid, can we expect bruise or like ecchymosis over there?
Not necessarily.
Right.
No. But are you going to expect that with a carotid as well?
Okay.
Now, palpation's your easiest and best bet. It's done. You're only looking for a reason to send this back to the emergency room or to send it to the emergency room. That's all you're doing, really. Yeah. Okay. Essential illness script for a fractured fibula.
And it is pain, where the injury is, fractures, and inability to weight bear.
Okay, wait a minute then. So what's your first one? Like the given is ankle pain, lateral ankle pain, yeah?
Okay.
That's what you're given, basically. Okay, so we've got lateral ankle pain. Now what?
Inability to weight bear, functional loss.
No, not by itself.
Tenderness and palpation.
Tenderness where?
The later aspect of the
Lateral aspect,
ankle.
maybe the posterior
Okay.
1/3, because that's a ankle roll is there too, right? So probably when we just palpate the posterior part of lateral malleoli, I believe. So I'm not sure about that one.
It's a posterior aspect of the fibula.
Yep.
Okay, and the reason it's posterior, if you palpate the anterior, you're also palpating a whole bunch of stuff there, including the lateral ligament, which is the differential for this. Yeah. So, are you familiar with the Ottawa ankle rules?
Yep.
That's it. I mean, that's all you need. If it's not been X-rayed and they're in breach of the Ottawa ankle rules, you're obliged to get them to the emergency room for an X-ray, because that should have been done anyway. If that had gone to the emergency room rather than to you, or if you're on a field with these people, then the ER docs should have done an ankle X-ray. Now, these protocols are there to make sure that you only do the X-ray when it's necessary. They're not that greatly diagnostic of a fibular fracture or a neck fracture or anything else. What they are there for is to make sure you do an X-ray when there's a good chance that there's a fracture there. So these things are close to 100% sensitive for fractures. Nearly all of these X-ray protocols are close to 95, 100% sensitive. But the specificity varies according to which one you're doing. And they only run about 40% or so. So there's a good chance the X-ray is going to be negative. There isn't a fracture there. But that's not your worry. Your job is to follow the protocol. So if it hasn't had an X-ray and they should have had one, if they got their doctor and the doctor didn't order an X-ray, they went to the ER and they didn't order an X-ray, they should have done. That's the point. So if you're seeing them with a few days of trauma, they need an X-ray. If they've been walking on this for 8 weeks and they're still having trouble, the X-ray is a little less urgent, but the chances are they have fractured it. Yeah. But we come back to the same thing. Sudden onset of the severest pain, but you don't know what it's going to be like the next day. That severest pain may be the following day. Yeah, because an ankle injury can be really severely painful. It's actually not being able to weight bear more than 4 or 5 steps, I think it is. It's the same with the knee, not just not able to weight bear, because you can hobble on it. Yeah, but if you can't do it for more than 4 or 5 steps unassisted, then that's one of the signs. Yep. So look for these fractures. Look at the X-ray protocols. All right, you got the Canadian C-spine rules for the neck. You got Ottawa ankle, Ottawa knee. The rest of these are a bit iffy. There are other ones out for ankle fractures, but they're not ankle fractures. I think there's one for wrist fractures, but they're not as good as those 3. So look at those. All right, remind yourself of those. And if I remember rightly, on YouTube, I've got a video on there on these protocols under webinars. If you look at the webinars up there, it'll be on there, I think. If it's not, let me know, because I know I've done one. But they're your authority on fractures. Like for a neck fracture mine's exactly the same as the ones for ambulance EMTs picking somebody up in a traffic accident. Basically, immediate onset of pain after trauma, central pain. Probably not the best idea is to palpate it, but central tenderness as well. And that's enough for them to immobilize the patient, get them straight to the emergency room. Should be enough for us as well. especially if the pain's high. All right, essential illness script from Morton's neuroma. That's actually a misnomer as well. It's a Morton's neurofibroma, actually, not a Morton's neuroma. But it doesn't really matter.
Pain elicited on compressing the metatarsals.
Now let's go back a bit, shall we? Start logically as if you're talking to the patient. That's not the first thing you're going to do with the patient, is it? What's the first thing you get from the patient? Where the pain is.
That is the pain.
Where's the pain?
And it will be in the forefoot.
Sorry?
Pain in forefoot, like on the toes.
Yeah, where on the toes?
They'll say on the sole of the sole, on the.
It can be dorsal,
Okay.
but it's the metatarsals. Okay, let's do this. We've got the language. We should be using the language. We've got technical terms for this. This is pain between the metatarsal heads, isn't it? So it's in the transverse arch. Usually one specific point in the transverse arch. Yeah. So we've got transverse arch pain. What sort of pain?
It'll be a burning sensation, burning pain.
It's got to be neuropathic, hasn't it? If this is a neurological problem, it's got to be neuropathic. So yeah, coursalgia. It may be paresthesia. It can be a sharp lancinating pain, although that's less common. So we've got neuropathic pain. Yeah. What makes it worse?
Weight bearing.
Okay, yeah, so it's weight bearing, as is with most things in the lower quadrant. So most things in the lower quadrant are weight bearing, so but that's true. Shoes or without shoes?
With
The shoes.
With shoes.
Depends on the shoes.
Tight shoes.
tight shoes.
Tight shoes, yeah. So they may well be more comfortable without shoes on. So you have to go that one extra step. What sort of shoes are we talking about? And it's going to be stuff that will squeeze them together. And your test for this is, as you say, grinding the metatarsal ribs together and reproducing the pain. Yeah. Okay, now let's do it without the neuropathic pain. What we've got now is somatic pain between the second and third metatarsals. So metatarsalgia is a perfect.
Can you repeat that, Jim? What you said? Sorry. Can you repeat what you just mentioned?
Yeah, it's pain, not somatic pain now, not neuropathic pain. Somatic pain between the second and third metatarsals. You fighting with somebody there, Sarath? Okay, so metatarsalgia is a perfectly good name until you can do better. Pain in the metatarsals, yeah. So, what's your essential illness script here? Well, you've actually got it from metatarsalgia. I got pain in my metatarsalgia is metatarsalgia by definition, yeah. We have to have a look at what else this might be. So, what might the metatarsalgia be caused by?
Can be due to the bursa over there. Irritated.
Okay, now you've got two bursa there. One of them runs under the heads, all the way under the heads of the metatarsals. And there's another one that may actually be the same bursa, but it acts as if it's not, that projects up between the metatarsals. Now, if it's a whole bursal area, all of the metatarsals are going to be a problem. Yeah, that it's going to be painful underneath all that. If it's between the metatarsals in one area, you may only have this point pain, which we're talking about here. So, how do you know? Let's say it's a generalized bursitis, the whole bursal sac and the metatarsal head is inflamed. What's your illness script for that? Metatarsalgia. What else?
Yeah. Yeah.
Can we ask some questions regarding their occupation, like what
No.
they've been doing?
No, because it doesn't work. I am, okay, you can ask me that. I'm a 75-year-old woman and I've retired. I am a gymnast. I spend all my time training during the day. I'm 19 years old. I don't work other than do that. I am an office worker. I am a warehouse man working on hard concrete floor. I'm a cook. So which one of those is going to cause it?
Can we ask which part of the walking phase the pain increases?
It's when I'm coming over on the toes, as I'm stepping over my foot.
So walking
Specifically, we just
barefoot
ask
will-
whether it's push-off phase, it's
As I'm
increasing
coming over,
pain.
as I'm coming over onto my foot, over my foot. Don't forget, you're
Walking-
talking to a patient here. I don't. What the hell are you talking about? Push-off phase. I don't know what the hell we're talking about.
So walking barefoot will be more painful than walking
Yeah,
with
walking
shoes.
barefoot's going to be worse than walking with shoes on, almost certainly. Yeah. You can do the same test you did for mortal neuroma. You can rub
Yeah,
the
squeeze.
metatarsals together, grind them, and see if that hurts. Yeah. Another cause of metatarsalgia. What have you got? Because this isn't an uncommon complaint.
Stress fractures.
Stress fracture. Okay. Talk to me about it.
Again, same pain when
Okay, what's in most cases, this is unfortunately not one of those cases. In most cases, although it probably will be, in most most stress fractures, what's the commonality between them?
It could be a traumatic incident or something like that.
That's not a stress fracture.
it's a repeated stress.
Well, not just repetitive stress. We all do that. We all walk. We're up on our feet all day long. We all repetitively stress the foot.
In athletes?
Doesn't have to be an athlete. It has to be an idiot. It has to be somebody who's doing so much and so stupid levels of activity that they're stressing the spine out. Yeah. That's a commonality with all this. So if this is a stress fracture, we expect to hear that. Now, the question you should have is, why that foot? Why not the other one? If they're doing a symmetrical, stupid activity, why isn't it stressing out both feet?
It might be calf muscle, gastrocnemius tightness on that side, which is.
Sorry.
It might be gastrocnemius tightness on that side, which is not allowing.
Everything's gastrocnemius tightness. How does that work? Why would that be an issue? I've never understood this. Gastrocnemius tightness is responsible for plantar fasciosis. It's responsible for stress fractures. It seems to be responsible for almost everything that hurts the foot. And I've never understood why that is. If you can lay out a reasonable sequence of events, why that would cause all of these problems, I'd appreciate it. And if you're going to say gastroenteritis, my next question is, why is it gastroenteritis? There's all sorts of reasons why this stress fracture may be affecting that foot. One of them may well be peroneus weakness. If the peroneus isn't doing its job properly, you'll come down on the second metatarsal, and you shouldn't be doing that. It should be high in the arch. So if the arch has dropped for any good reason at all, then you're going to start coming down onto the second metatarsal rather than the first metatarsal. And the second metatarsal isn't built for that kind of stress. So that can break down. So we've got stupid amounts of stress. We don't know about the causes of it, but we've got stupid amounts of stress. What's your definitive test here? This actually applies to almost any stress fracture.
Ultrasounding that area.
Hmm?
Ultrasound.
No, you can't always rely on that. I have no idea of the sensitivity of that or the specificity when it comes to it. Law tuning forks. Palpate the bone. I mean, there's only one reason why a bone is tender. It's infected or it's fractured. They're the same thing, basically. So palpate the metatarsal head. Yeah, not between metatarsals. Then you can do stuff like ultrasound, see if that's painful as well. But I have no idea. And if you're going to use ultrasound, it's maximum intensity, unpulsed, and a smooth, slow motion over the area. Yeah. You can also try compressing it. So you grab on one end and you can press the other end into it. Calcaneal fractures, it's a squeeze test. Yeah. Tibial fractures are more difficult, but you can thump onto the calcaneus, see if you can cause pain up in that area. Yeah. But there are two things: palpate the bone and a history of stupid amounts of exertion. Yeah, that's your illness script. What you're looking for here is not to actually make the diagnosis. The diagnosis will be made by imaging, but find a reason for the physician to order the appropriate imaging for this stuff, which is usually uptake scans, isn't it? Anything on any of that stuff? The foot's really interesting. There's a lot of shit goes on the foot. So let's move to the heel. Under heel pain. This is pain on the heel pad area. All right. Skin, bursa, fat, bone, attachments and muscles. We've got pain on the heel area, inferior heel area. There is a subcalcaneal, or also called subcutaneous bursa, which gets confusing because there's another one overlying the Achilles tendon. But this one is sitting under the skin on the heel pad. So we can have a bursitis there. So illness script for bursitis, what have you got? In general, don't care where it is, shoulder, heel, bursitis in general. What's your illness script for that?
Distraction relieves the pain.
Pardon?
Distraction of the joint relieves the pain. Relieve pain.
No, because most of these have got nothing to do with the joint. Why would distraction of the joint relieve the pain?
That most commonly we just test in shoulder, right? So if the patient is just having a longitudinal distraction, if the patient complains there is a ease of pain, so probably we might think of a bursitis in the shoulder, right? So probably.
No, you've got some big bursas there. You're just thinking about the subclavian one, subacromial. You've got subdeltoid bursa there. But it's not being pushed up. It's not that the shoulder's pushing up against it. It's already hanging there. So it's not really compressing that bursa. And it probably won't relieve it because is it painful at rest? This is the question. Is that painful at rest? Is that bursa painful at rest? When they're just standing there and holding like that, is it painful? Have you ever seen one that is? I've seen these be extremely acute, so severely acute they can't move their arm at all. At rest, though, they're not painful. So distracting it is not going to relieve the pain because they don't have any. Yeah.
Usually it's painful on compression of the bursa.
Okay. Fair enough. How are you going to compress it? What's the most
Do you
common
have
way?
Well, if you're talking about the heel one, stand on it.
No.
No.
Because you're compressing the.
Or push it. Push on it.
Yeah, palpate it. That's always your go-to technique. Palpate the bloody thing. If you want to compress something, push on it. Yeah. The trouble with standing on it, you're also compressing the fat pad, the bone, everything is getting compressed when you stand on it. And you know it hurts when they stand on it because they've just told you that. Yeah. So all you're doing is saying, okay, I want to see for myself if it really does hurt. Stand on it. Yeah, that hurts you silly. So I told you it does. Yeah. So palpate it. But really what this is, the way this works is that a bursa is a diagnosis of exclusion. When you've excluded everything else, you're sort of left with a bursa. Yeah. And then palpate the bursa. Now, if you can find ways of stressing it other than palpating it, that's good as well. Psoas bursa, for example, if you lay them on the end of the bed, let the leg overhang the bed so the hip's extended, and then have them contract the flexors, the hip flexors, then that psoas tendon will bowstring down onto the bursa, and that may do it. You're thinking about distracting it. If I do that, if I actively move them up it, passively rather, moving that range and it gets caught underneath it, if I distract it and pull up and it doesn't, that's an indication it's a bursa as well. Yeah. But you get rid of the other diagnoses first. Exclude them. The subcalcaneal subcutaneous bursa, you can see it sometimes. It can get very swollen, and if it's also red, you now have to worry about it being infected. So the illness script for an infected bursa anywhere is basically a rapid onset of swelling and pain, redness, and then take their temperature, and the temperature may or may not be increased. But that red area where the bursa is, severe tenderness, get them out, because if that is infected, they're in trouble. Okay, while we're on the hill, fat pad atrophy. What's your illness script? Anybody? Start the pain again. Start with the pain. The pain's on the hill. Yeah. How does it behave?
Supporting the heel and palpation will reduce the symptoms.
Well, but functional behavior now. What makes it hurt?
Walking bare feet will hurt, and walking with supported, like some nice shoes, will relieve the pain because some padding was there.
Sorry, what was that?
So walking with bare feet increases the pain, and walking with some footwear with nice supported heel might relieve the pain. They feel it's comfortable.
They're probably going to be more comfortable in shoes and not wearing shoes.
Yeah.
All right. So like really comfortable shoe wear is very subjective. Yeah. But walking with shoes is almost certainly going to be better than walking without shoes. Walking on carpets is going to be better than walking on tile. Yeah. And it's going to be pain on every step they take. Fair enough. Now, on testing.
There'll be tenderness on palpation, but once you support the heel, the tenderness might ease up a bit.
No, that's a different animal. If they've got fat pad atrophy, generally speaking, what is tender? What structure is tender when you palpate it? Not the fat pad, what is it?
The calcaneum.
Yeah,
Okay.
you can palpate the calcaneum here, and that's tender, not the fat pad, because it ain't there. Now, a spread, if you've disrupted the fat pad and it's spread out, and you squeeze the edges of the fat pad and then palpate, if you can't get to the calcaneum and it's not tender, then you've got this spread out fat pad. Okay. And typically, I don't know if you've noticed this or not, but if you're treating plantar fasciosis now, that treats really quite well with shockwave. Actually works quite well with it. Unless there's an atrophied area in there, then the atrophy is caused because of changes in the way you weight bear because of plantar fasciosis. So you actually wear the fat pad away in an area. It's a small area, but that stays painful. That's where you can feel the calcaneum, and that's a bitch to treat. So fat pad atrophy is very difficult to actively treat. You end up trying to find surfaces that will cushion for them. I'm not sure, but I think shockwave may also help that. I didn't do enough of it to really find out, but it did seem to help a few people. And you see that with plantar fasciosis. We talked about bone cysts and fractures of the calcaneum. Squeeze test, you squeeze the calcaneum from side to side. Yeah, probably the easiest way of doing it, the edges of your hand that way. And if that's not positive, you then push on the back of the heel and the talus, and you push longitudinally through it. And that's positive for bone cysts and stress fractures and pathological fractures as well. Okay. So there's your illness script for that. You can also get fat pad inflammation, in which case now the fat pad is inflamed. So you can't palpate the calcaneus, but the fat pad itself is tender. Okay, now the biggie. Essential wellness script for plantar fasciosis. Now let's do the other one, plantar fasciitis. Essential wellness script for plantar fasciitis.
Morning pain on weight bearing.
Okay, so pain's up after prolonged periods of non-weight bearing, particularly in the morning, yeah? Is that okay?
Yeah.
Yep.
Yeah.
Okay.
And medial calcaneal cubicle tenderness.
Yeah. So you give me one behavior, one sign. Any other behavior, pain behaviors?
Uses up after moving.
Yeah, it doesn't.
If it is.
It actually gets worse. The more you do, the worse it gets.
Yes, it is.
If we're talking about plantar fasciitis, this is an inflammatory condition. What other inflammatory condition improves the more you stress it?
No, don't.
This is the fault of our language. It's not being used properly. Undiagnosed or unstaged, if you like, plantar fascial problems is like unstaged tendon problems. It's a tendinopathy or it's a plantar fasciopathy. Yeah. Then you stage it into a fasciitis or a fasciosis. One's inflamed, one's degenerative. Now, the fasciosis typically does exactly what you said. It's painful more after prolonged periods of weight bearing, and then improves as you do a bit more. If you do too much, it's aches at the end of the day, though. It still does. Yeah. Fasciitis, though, isn't. It may well be worse when you first get onto it after a period off of it, but then each step hurts, and it generally gets worse and worse and worse during the day. Plantar fasciitis is uncommon, very uncommon, and it's usually caused by systemic medical conditions. Systemic arthritis, gout does it. I know gout does it. So these tend to be medical conditions. You can tear the plantar fascia, and that's a sudden onset from trauma. It's and it's usually further down the foot. But you're quite right with plantar fasciopathy, whether it's fasciitis or fasciosis, the tenderness tends to be in that medial campanile point. Now, with fasciosis, you really have to dig in there, don't you? You have to apply a lot of pressure. And generally speaking, you use something else, a pen tip or something to get in there. Yeah. With a fasciitis, it's much easier to feel this thing. Kicks in straight away. Is that okay?
Yeah.
Right, so what I'd like you to do, if you would, look at some of the more common conditions and critically look at them, all right, and see if your experience with these actually matches what you're taught and what you're using for your diagnosis. Really think about what these actually look like when you see them. And if you haven't seen it like plantar fasciitis, see if the description of its behavior makes any sense to you. Now, you're going to need somebody else to give you the EISs initially because you haven't got the experience for it. But this is actually sort of a shortcut into pattern recognition. In fact, it's arguable this is a better way of doing pattern recognition. But it really is the minimum necessary. And break it down. Tendinopathy, tendinitis, tendinosis, central stenosis, with radiculopathies, without radiculopathies. Yeah. And don't look at the mechanism of injury. It really doesn't help very much. Most of the stuff you see don't have a mechanism of injury. More people hurt their backs taking stuff out of the trunk of a car than putting stuff in the trunk of the car. Why? Any thoughts? I'm glad nobody's got eccentric versus concentric and all the rest of this stuff. It's because the back's been pre-damaged. They've driven somewhere. If they have a back problem, they've driven somewhere and it's sensitized the back. Then they go and pull something out of the trunk of the car and then they're in trouble. Right? So the mechanism isn't always particularly useful. In fact, it rarely is. Unless you're looking for healthy tissue damage and degenerative tissue damage. Somebody who's picked up 20 pounds of potatoes and they suddenly hurt their back, that hasn't blown the disc, that hasn't done this stuff. Somebody who's carrying a 500-pound weight with somebody else and the other person lets go of that and then they suddenly take all of that weight, that's a reasonable reason for suspected compression fractures, disc herniation, all the rest of this. But the mechanism of injury is good for determining whether it's healthy tissue disruption or degenerative tissue disruption. But really, that's about it. So when you're looking at the patient's complaints, only look at their presentation. Don't worry about other stuff. Age does come into it a bit, but you can diagnose central stenosis without worrying about their age. You'll bring the agent out later on and go, okay, this doesn't make any sense. Why not? But you make the diagnosis based on the patient's presentation. Okay. You good?
Yep.
All right, guys, I will see you next Sunday. Have a good week. Hope the weather keeps getting better for you, because I'm there soon, so it's got to get better for me. That's the main thing. All right, guys.
Yeah.
I'll see you then.
Thanks, Jim.
See you.
Take care,
Bye-bye.
buddy.
Bye.
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 Bye.